right, welcome everybody. We're just getting started in just a couple of minutes. We have a few more people who are logging on. In the meantime, I'd love if you all could share with us where you're calling in from. We have people who are calling in from all over the world, so please let us know in the chat where you're calling in from, and we'll get started in just a minute. Excellent. We got people from Los Angeles. Hello. People from Phoenix. Tampa, New York. Hello. I'm calling in from Omaha. San Antonio. LA, a lot of LA. Excellent. Great. Okay. All right. I think with that, we can go ahead and we'll get started. So, welcome everybody. This is the Childhood Liver Cancer Diagnosis, Treatment, and Hope webinar that is featuring Dr. Allison O'Neill of Dana-Farber Boston Children's Cancer Institute and Dr. Arun Rangaswami of UCSF Benioff Children's Hospitals. This webinar is brought to you by Eureka Therapeutics and Eureka Connect Me. My name is Nicole Nunez, and I'll be your host for today's webinar. I'd like to first give you an overview of the different topics we're going to discuss today. First, I want to go into what is the purpose of today's webinar, as well as provide you with the history of Childhood Cancer Awareness Month and what it means to us. Next, I'd like to introduce our first physician speaker, Dr. Arun Rangaswami of UCSF Benioff Children's Hospitals. He will discuss what pediatric liver cancer is, different subtypes, signs, as well as the path to diagnosis. Next, we'll pass it off to our second physician, Dr. Allison O'Neill of Dana-Farber Boston Children's Cancer Institute. Dr. O'Neill is going to talk about different treatment options as well as clinical trials and when to consider them. Next, we'll have our final speaker, Dr. Pei Wang of Eureka Therapeutics, Inc., who will go over what T-cell therapy is, as well as the ARIA-2 clinical trial for relapsed refractory pediatric liver cancer. Last, we'll have a questions and answers section where you have the chance to ask your questions directly to our speakers. To participate, just add your question in the Q&A box. You can see that at the top of your screen, and you can ask a question at any time during the webinar. We're going to go over them at the end of the talks. All right, with that, let's get started. I'd like to start first with what is our purpose for this webinar. And it really is to serve as a resource for the pediatric liver cancer community by providing information about this disease, as well as current and new treatment options, and by connecting patients with physicians. We hope that you find this webinar helpful. This webinar was also put together in honor of Childhood Cancer Awareness Month. I'd like to take a moment to go over briefly what the history of Childhood Cancer Awareness Month looked like. It actually started back in 2008 when Senator Allard and Senator Clinton put together the National Childhood Cancer Awareness Day resolution, which would recognize September 13, 2008 as the National Childhood Cancer Awareness Day, and it passed. Then in 2012, President Barack Obama issued the first presidential proclamation for the National Childhood Cancer Awareness Month. Then in September 2019, Senator Manchin introduced literature to Congress that would make National Childhood Cancer Awareness Month official, and it passed unanimously on September 26, 2019. And ever since, on September, we recognize childhood cancer, and we try to bring awareness about this disease so we can spark conversations as well as innovations to help combat it. With that, I would like to then introduce us to our first physician speaker, Dr. Arun Rangaswami of UCSF Benioff Children's Hospitals. Dr. Rangaswami is the lead pediatric hematologist, oncologist, and professor of clinical pediatrics. He is a senior solid tumor faculty at UCSF. He is the co-chair of the Children's Hepatic Tumors International Collaboration and facilitates the International Hepatobiliary Multicenter Tumor Board. He is the author of dozens of publications and the PI of many well-known clinical trials in the pediatric liver cancer space. With that, I would like to pass it over to Dr. Arun Rangaswami.
Thank you very much, Nicole. I want to thank the organizers and Pei and Nicole and everyone who's attending to have this opportunity to talk to you all about this very important topic. Of course, in honor of Childhood Cancer Awareness Month, which is September, but also Liver Cancer Awareness Month, which is October. Next slide, please. I have no disclosures. So I'm going to discuss the following points. I'll provide an introduction to pediatric liver tumors with an overview and clinical presentation. I'll talk a bit about hepatoblastoma and predisposing conditions that cause it. I will talk about the SHEIC collaboration and also touch on the Pediatric Cancer Data Commons. Then we'll turn to hepatocellular carcinoma, and I'll provide an overview in epidemiology, again, cover predisposing conditions, and then I'm going to turn it over to my colleague and my friend, Dr. O'Neill from the Dana-Farber, who will discuss treatment. So pediatric liver tumors are interesting in that 2/3 of all the liver masses in children are malignant. And malignant liver tumors account for approximately 1% of all childhood malignancies in the SEER database. There are 100 to 150 cases of malignant liver tumors in children each year in the US, and of these, 2/3 are hepatoblastoma. And the approximate distribution of liver masses by diagnosis listed below shows hepatoblastoma and hepatocellular carcinoma, including fibrolamellar carcinoma, being the two dominant histologies. Next slide. The clinical presentation is usually it's an asymptomatic mass that's detected by a parent or a physician on physical examination. When there is advanced disease present, one can see abdominal pain, weight loss, anorexia, vomiting. And jaundice and liver function test abnormalities are rare in hepatoblastoma, but can be present in up to 20% of hepatocellular carcinoma patients. In hepatoblastoma, we often see elevated platelet counts or thrombocytosis due to the fact that the tumor produces thrombopoietin, a hormone which stimulates platelet production. And the alpha-fetoprotein, or AFP, is elevated in 90% of hepatoblastomas, and elevations in AFP are also quite common in hepatocellular carcinoma. Turning to hepatoblastoma now. As I mentioned previously, hepatoblastoma is the most common primary liver neoplasm in children under 15 years of age. The incidence is 1.6 cases per million. However, there's an increasing incidence of 4% per year in the US and 2.5% per year in the European Union. There is a slight preponderance of this occurring in males. And known clinical risk factors include extreme prematurity, very low birth weight, parental tobacco exposure, prolonged stays in intensive care nursery, and congenital anomalies such as polycystic kidney disease and congenital heart disease. There are associations with cesarean sections, and the relative risk of hepatoblastoma is inversely proportional to birth weight. And in addition to these associations, there are associations as well with exposure to erythropoietin, ionizing radiation, total parenteral nutrition, and fertility medications. Late effects of treatment are principally sensorineural hearing loss. However, there's a slight incidence of secondary cancers, of impact on growth and development. When anthracyclines such as doxorubicin are used in treatment, there's a risk of cardiomyopathy and then peripheral neuropathy. And in patients who receive a liver transplant, PTLD or post-transplant lymphoproliferative disease is a risk. And the identification of prognostic factors has really allowed us to further individualized therapy, although we continue to unfortunately have a limited understanding of the biology of the disease. However, our understanding is increasing rapidly. In hepatoblastoma, there's metastatic disease in approximately 1/5 of patients, with the lung being the most common site of metastasis. Rarely, one can see metastasis to the brain or to the skeleton. And most cases are unifocal. And so that means only one large tumor or small tumor. However, in 20% of cases, there can be more than one focus of tumor. Most cases of hepatoblastoma arise from the right hepatic lobe, and 85% of them contain fetal and embryonal components. This is a graph taken from the SEER database, which is the National Cancer Institute's Surveillance, Epidemiology, and End Results database. And this is from 2017. And one can see here in the blue that the incidence of hepatoblastoma decreases with age as the incidence of hepatocellular carcinoma in red increases. There are known predisposition and genetic syndromes that are associated with an increased risk of hepatoblastoma. These include having a mutation in the FAP or APC gene, that's familial adenomatous polyposis, or the adenomatous polyposis coli gene, the presence of Beckwith-Wiedemann syndrome, isolated hemihyperplasia, and other overgrowth syndromes such as Prader-Willi, Soto's, Simpson-Globby-Bemmel, and Kabuki. There's also an increased incidence of hepatoblastoma in NF1 or neurofibromatosis patients, and in trisomy 18 or Edwards syndromes patients, and in patients with hereditary hemorrhagic telangiectasia. And as I mentioned previously, there's an increased risk in association with congenital anomalies. I think, as we mentioned earlier, the most common presentation is an asymptomatic right-sided abdominal mass. And one can see thrombocytosis in 60% of patients. I again emphasize the elevation of alpha-fetoprotein in over 90% of cases, and the median level at diagnosis is greater than 10,000. And this is relevant when we talk about treatment strategies. There's metastatic disease in 20%, and staging studies include CT scan of the chest and MRI with a hepatobiliary contrast agent, Eovist. There have been historically two different staging systems, the COG staging system or the Evans staging system, which is a purely surgical staging system, dependent on the level of resection of the tumor at diagnosis, and then the pre-treatment extent of disease staging system, which was developed by PSYOP, and that is based on the number of liver sectors involved. It also includes factors such as the degree of extrahepatic extension with or without metastasis, and it does help to guide resectability, although of course this is ultimately determined by the surgeon. And this was developed due to the European strategy of giving preoperative chemotherapy. And in a multivariate analysis in the SIOPEL-1 trial, it was shown that pretext staging was the only predictor of overall survival, and probably is a surrogate for being able to resect the tumor. In addition, metastatic disease was also predictive of event-free survival and overall survival. So one of the major developments in hepatoblastoma has been the development of a risk stratification system. Because it's a rare tumor, there are inherent challenges. And historically, there have been four major international cooperative groups based in Europe, in North America, in Germany, and in Japan, who studied hepatoblastoma and developed treatment protocols. All of these groups had variable approaches to staging and treatment, and this hampered the development of a uniform risk stratification system and a pathologic nomenclature. In a response to this, in 2012, leadership from all of the four cooperative groups came together and founded the Childhood Hepatic Tumor International Collaboration, which resulted in the largest database extent in pediatric rare tumor. There were initially 1,605 patients in the database, and these comprised patients enrolled in four cooperative group trials, trial groups, reflecting the composition of SHEIK, and 8 clinical trials total. And here you can see that in the initial development data set, we had data inputted from the Children's Oncology Group, from the Japanese Pediatric Liver Tumor Group, SIOPEL in Europe, and then the German Pediatric Oncology Hematology Group, which eventually merged with SciPal. And more recently, we've had a validation data set of 500 patients or so, which were reflective of contemporary clinical trials, which, in the end, we were able to analyze out of those 500 patients, 403 patients. And as a result, we developed the following risk stratification system, which is based on the pre-treatment extent of disease, so pretext stage, as well as the presence of or absence of metastatic disease, the presence or absence of annotation factors reflecting macrovascular involvement, extrahepatic extension, preoperative rupture, and multifocality, and as well considering the patient's initial alpha-fetoprotein. In addition, as you can see here, for pretext 1 and 2 tumors, resectability was also important in stratifying patients to an individualized therapy regimen. And this shows a similar risk stratification tree for patients with pretext 3 and 4 disease. These are typically patients that are not resectable at diagnosis. And so once again, one can see the influence of these important annotation factors in guiding stratification of patients to low, intermediate, and high-risk treatment groups. I want to turn briefly to the Pediatric Cancer Data Commons, or the PCDC. Historically, the SHEIC data was housed in a European-Italian, actually, inter-university supercomputing database called Cineca. However, it became clear that Cineca could no longer host our data, and therefore we explored a collaboration, which we then initiated with the Pediatric Cancer Data Commons, which was established in 2015. It provides a hub for research across all pediatric and AYA cancers, facilitates cross-disease research, and develops common core data dictionaries, and creates a common governance structure, builds an active international network of researchers, and educates, trains, and increases data literacy of the community. Sources for this data emerge from clinical trials, from registries, and soon electronic health records. And it provides links between data sets. I'll turn briefly now to hepatocellular carcinoma. It's the second most common primary hepatic malignancy in children and comprises 5% of all cancers worldwide. It's the fifth in frequency of malignancies worldwide, and survival rate decreases with age. Local, regional, and distant disease is associated with poorer prognosis, and unresectable disease is associated with dismal prognosis. In terms of epidemiology, pediatric hepatocellular carcinoma cases are rare, and there's only 0.8 to 1.5 cases per million in the United States. 2/3 of these cases occur in children greater than 10 years of age, and this accounts for 87% of malignant liver tumors in patients 15 to 19 years of age. It's the second most common primary hepatic malignancy in children after hepatocellular carcinoma, and there are higher incidences in Southeast Asia, and Africa, where hepatitis B and C are endemic. Prognosis is significantly worse than hepatoblastoma, principally because less than 20% of these patients are eligible for upfront resection, and they are less chemosensitive than hepatoblastoma. The median AFP at diagnosis is 51,000, with a range of 1 to 4 million. And AFP is greater than 100 in 20 to 30% of, less than 100 in 20 to 30% of cases. There are a number of known predisposing conditions, which are listed here. And in the interest of time, I think we'll move on to the next slide. And that concludes my presentation. I want to thank my fellow steering committee members in SHEIC, and I also want to thank my friend and colleague Allison O'Neill, who leads the COG Liver Tumor Committee, and then Greg Tiao, who's a pediatric surgeon who was the PI for the most recent treatment strategy. And most of all, I want to thank our patients and families. All right. Thank you, and we can take questions now or afterwards.
Great. Thank you so much, Dr. Rangaswami. Next, I would like to introduce our next physician speaker, Dr. Allison O'Neill of Dana-Farber Boston Children's Cancer Institute in Boston, Massachusetts. Dr. O'Neill is a pediatric hematologist oncologist and clinical director of the Solid Tumor Program. Dr. O'Neill is also the medical director of the Liver Tumor Center of Excellence, and Dr. O'Neill's research interests lie in the development of novel therapeutics for pediatric patients with solid tumors, and particularly those patients with liver tumors. Dr. O'Neill is the author of dozens of research publications and PI of many well-known clinical trials in the pediatric liver cancer space. With that, I'd like to pass this over to Dr. O'Neill, who will share her slides on different treatment options and clinical trials. Dr. O'Neill.
Thanks so much, Nicole, and thanks to everyone for the opportunity to be here today. It's a real pleasure, and it's so nice to see so many of you signed in, including some familiar names. I want to make sure that you can see my slides. Can Nicole, can everyone
Yes.
Can you see this? Great, perfect. All right, great. Well, like I said, it's a pleasure to be here today, particularly during Childhood Cancer Awareness Month. It's great to follow my colleague and friend, Dr. Arun Rangaswami. We know each other well through the Children's Oncology Group, of which I chair the Liver Tumor Committee, and have had the pleasure of working for a long time together and with our team of colleagues. So I'll talk a little bit about therapies for relapsed or refractory pediatric liver cancers, recognizing that Arun's talk stopped short of talking about current therapies, but I'll touch on those briefly as well. You've since heard of the two most predominant diagnoses within the pediatric community for liver tumors, those being hepatoblastoma and hepatocellular carcinoma. We also recognize that there's a hybrid entity called hepatocellular neoplasm not otherwise specified. And curiously, this is a tumor that looks under the microscope a lot like hepatoblastoma, a bit like hepatocellular carcinoma, and either there are cells of both tumors or hybrid cells that have characteristics of both. These tumors tend to occur in children approximately 6 years of age or older, and so we're always hesitant in the pediatric community when we're met with a diagnosis of hepatoblastoma in an older child, because we tend to know that over the age of 6, outcomes are different, and that these tumors tend to behave more like hepatocellular carcinoma, presumably secondary to these mixed features and a more aggressive genomic risk pattern. It's really hard to categorize the risk of relapse. The literature is scattered, and what we know is that the incidence has been reported anywhere from 6 to 50%, which is an extraordinary range. What we've come to recognize over the years is that the incidence largely depends upon the risk categorization at diagnosis. For instance, the higher risk disease at diagnosis portends a greater risk of relapse. Our European colleagues amassed all data from the first 3 trials they conducted as a consortium, and they found out that of about 600 patients, 10% or so had relapsed or progressive disease. While 52% or over half received a second remission, we recognize that outcomes are still very poor in this patient population. Only about 30 to 40% of children achieve a long-term cure. We similarly looked in the Children's Oncology Group at our recently concluded clinical trial, not the international trial that just closed, but the one conducted prior to that, which enrolled about 200 patients. And we found the same thing. If you were in a low risk or favorable stratum, very few patients recurred. Intermediate risk patients, the rate was higher. High-risk patients, i.e. those with metastatic disease, almost 50% recurred, and it was difficult to place those patients back into a remission. And we know then that the success of salvage is poor. What we know is important for cure is eradication of all sites of disease. So then how best to do that? You really need a combination of 2 approaches. Systemic therapy. The majority of patients are previously exposed to their top 2 drugs of choice. So I haven't gone into great detail about how we currently treat hepatoblastoma or hepatocellular carcinoma or that hybrid entity, but we know that cisplatin is the mainstay of therapy. It's the backbone of most protocols, and it's our most valuable drug. Comes with a lot of toxicity and long-term sequelae, but it is the most effective drug we have. We also know that a fraction of patients are exposed to doxorubicin, the second most commonly utilized chemotherapeutic. So where do you turn from there when patients recur? We know that systemic therapy is so important, particularly in patients who recur in more than one site, but we also know that local control measures are of equal importance. You need both to achieve cure. And by local control, I'm referencing either surgery, liver transplant if necessary, or other measures to locally or focally control disease, i.e. radiation or interventional procedures. There have been some successes noted in the literature, most notably for patients who haven't received doxorubicin in the past. We've found that those who haven't received in the past have very good responses when it's added in at the time of relapse. We also know more recently that reintroducing cisplatin for a subset of patients can be very valuable. These are typically patients that have had a beautiful response to cisplatin up front that then re-respond later on in life. That's not to say it's without end organ damage or toxicity, but we know that it's still a very useful drug for some patients if their disease is to return. There are other successes. There are other chemotherapeutics that we know work in the relapse setting, ifosfamide being one of them, often used in combination with other agents. Carboplatin, just kind of a cousin of cisplatin, has efficacy. And irinotecan is quite a common drug utilized both in Europe and in the US at the time of relapse, but we recognize that the drugs we choose are highly dependent upon the timeline of recurrence, the extent of disease at the time of recurrence, and in many cases, the genetic risk of that tumor. So tumors that have a higher genetic risk, i.e. have genes implicated that suggest that the tumor is of a more aggressive phenotype, we have to think a little more carefully about which agents we choose and what pattern, and when we incorporate our local control measures. There have been a lot of disappointments over the years. This article that I highlight here, written by Angela Trober-Lotario, one of our close colleagues, looked at historically all the other agents utilized in the context of relapse that have been published. She looked at a number of other chemotherapeutic agents, high-dose chemotherapy with stem cell rescue, radiotherapy, targeted therapies, and sadly, most didn't work. And I think what we're met with is that a lot of novel agents are limited in pediatric use, predominantly because children can't take pills. There are very few liquid formularies, and most drugs are developed in the context of adult diseases, not all of which are applicable to pediatrics. She then conducted a follow-up study and looked at all the clinical trials that had been run through COG, and similarly found that there were many disappointments for patients with recurrent liver tumors. We then embarked upon something called the RELIVE Registry. This is a global initiative that is led by Mark Ansari in Switzerland. And the goal was to collaborate with as many institutes as possible across the world, including 4 continents, and to predict on the basis of the current international trial that just concluded, that was run in the US, Europe, and Japan, how many patients in each risk category would we estimate being enrolled, and how many would we estimate will have relapsed. And then our goal was to accrue data all across the globe on what people were utilizing in terms of drugs at the time of relapse. Had these investigators been placing children on clinical trials? If so, what agents did they study? What kind of responses were we seeing? You know, many of the publications that are in circulation now have 5 or 10 patients apiece. It's really not enough for us to learn from. And so our goal here is to accumulate data on hundreds of patients globally. And we're in the midst of analyzing our data for relapse hepatoblastoma at present. So then let's talk briefly about novel therapeutics. What should we consider and when? So often we reintroduce chemotherapy first in our patients with relapse disease, recognizing that only in rare circumstances can we reestablish a remission. And we're thankful when we do, and often that remission is durable. But for many of our patients whose disease continues to grow through standard chemotherapeutics, we have to turn to targeted agents or immunotherapeutics. And these are often what are offered to children on clinical trials because they're novel, often they're first in child, and we have to study them in a rigorous fashion to know if they work and how safe they are for this patient population. I'll walk you through this slide, but I've kind of listed out which clinical trials are currently open and running for pediatric patients with relapsed hepatoblastoma, that being HB for short. There's a trial out of Cincinnati led by Dr. Geller that's studying cisplatin reintroduction with the concept that perhaps patients just didn't get enough cisplatin to start. These patients are receiving cisplatin alone or with the addition of something called an HDAC inhibitor or a targeted agent. There's likewise a clinical trial being led through the Children's Oncology Group in the Early Phase Clinical Trial Network looking at tegavivint. This is a drug that's intended to interrupt the Wnt beta-catenin pathway. That's a genetic pathway that is implicated in 90% plus of these tumors. It's enrolling patients across different histologies who have implication of this pathway, and thus far has been well tolerated, but we don't yet have results. Among other targeted agents, there's a drug called Allison 6924. It's a mouthful, but it's intended to interrupt DNA damage repair mechanisms. It's led by a PI here at Dana-Farber with multiple sites that have the trial open, and hepatoblastoma was a particular arm on the trial because there's some laboratory-based data to show that perhaps it's effective in this context. And finally, there's an immunotherapy trial led by Dr. Mike Ortiz with a sponsor out of Memorial Sloan Kettering, open at a number of sites, investigating an antibody called cotrotuzumab against GPC3, which is a protein that is specific to liver tumors. We'll then turn briefly to novel therapies for hepatoblastoma, this HCN-NOS, or that hybrid category, and hepatocellular carcinoma. First, we know that there's a lot of traction gained for checkpoint inhibitors. These are antibodies that interrupt the interaction between tumors and immune cells, turning the immune cells back on in a constructive fashion. They've been shown to be very effective in the adult world, but less effective in the pediatric world. So we're currently studying this in conjunction with a number of other institutes for patients with relapsed HCN-NOS and HCC. I will leave Pei to, in more detail, describe the Eureka trial, which is very exciting to us, utilizing a TCR mimic to target particular targets intrinsic to hepatoblastoma. We have colleagues that have engineered an armored CAR-T trial for relapse or refractory disease targeting GPC3. And then there's a subset of tumors that are completely different from conventional HCC that are called fibrolamellar carcinomas. These are unique entity, all their own. They don't look anything like HCC under the microscope, and they're characterized by their own genetic abnormalities for which there is a lot of work being done in the immunotherapy space to try and target these tumors. There are a couple pilot studies that we're working on through Children's Oncology Group, one for high-risk hepatoblastoma with the intent to decrease the number of children who have relapse disease and to get more into an early remission while trying to preserve hearing. And so we're hopeful that we'll be able to launch that clinical trial in the future, but it's a ways off. We're looking to conduct an early phase trial for that fibrolamellar carcinoma subtype that I mentioned. And we're really focused on survivorship, recognizing that no therapy is free. Of course, we want to prioritize long-term survivorship, but we recognize that every treatment comes with toxicity and risk, and we want to better understand how children are being affected in our community. I think the takeaways are that collaborative approaches are always warranted. Registries are extremely informative. Genomic profiling really tells us whether there's targets we haven't yet thought of. And laboratory-based drug screens are very valuable as well. But a clinical trial network in collaboration with sponsors such as Eureka and our pediatric community is so very valuable for this rare subset of children for whom we're struggling to find adequate cures. Perhaps the next international trial will have a relapse refractory arm from which we'll learn even more and be able to pose even more novel questions. But until then, I think the work that's being done now is inspiring. So with that, I'd love to thank the Children's Oncology Group, my colleagues, including Dr. Rangaswami, folks in Europe and Japan, the Relive Working Group, Eureka Therapeutics, and everyone here today, particularly patients and families. We're so very motivated to further the field and are excited to be here today. So thank you here today.
Excellent. Thank you so much, Dr. O'Neill. That was incredibly informative. Everyone, allow me to introduce Dr. Pei Wang of Eureka Therapeutics, Inc. Dr. Wang is the Vice President of Clinical Development and Technical Operations at Eureka and is the Principal Investigator under the California Institute of Regenerative Medicine for the ARIA-2 clinical program for pediatric patients battling relapsed refractory liver cancer. Dr. Wang also leads the overall strategic direction and operational excellence of clinical development department at Eureka and holds a PhD in molecular genetics and microbiology from UT Austin. With that, I'd like to pass it over to Dr. Wang.
Hey, Nicole, thank you for the nice introduction. I'd like to first say it's our great pleasure to have Dr. O'Neill and Dr. Rangaswami to join our webinar in honor of the Pediatric Liver Awareness Month. And it's also our great pleasure to meet all of you virtually here today. So in the next few minutes, I'll be very happy to walk you through Eureka's technology platform and the clinical program focusing on pediatric liver cancer. So Eureka is actually located in San Francisco Bay Area, and we're actually in this building for the past 18 years already. And next, Nicole, Eureka is actually focusing on developing the best T-cell therapy for solid tumors. Next, Nicole. Yeah, so we're focusing on developing the best T-cell therapy to fight solid tumors. And actually in the center of this slide, if you see, it's actually a picture taken by electron microscope. It's a real liver cancer cells, which is a HepG2 cancer cell line, which is stained in orange, and the round shape that's a T cell, which is stained in blue. And this picture clearly shows how our Artemis T cell is actually Artemis T cell interacting with the liver cancer. So it's a pretty cool picture. Next. So speaking of Artemis T cell therapy, or specifically in T cell therapy, it's one of the immune therapy, as Ali just mentioned. So we go through a process of taking out the patient's blood, just like the blood donation, and then we isolate the T cells, engineer the T cells. Of course, in Eureka's situation, we incorporate with our specific technology there, and then we grow and expand the engineered T cells, and then infuse the T cell back into the patients. And at Eureka, we are actually developing so-called autologous T cell therapy, meaning that we manufacture T cells specifically for each individual patients. So the uniqueness of the T-cell therapy at Eureka is we actually incorporate, as I just mentioned, two technology platforms. One is called E-alpha, the other is called Artemis. So in the center is actually our favorite cartoon. We call it Super T. Essentially, it's the T cell engineered with the power of both E-alpha and Artemis, and it became the Super T. And with that, the Super T cell with the E-alpha technology, the Super T cell can specifically recognize the cancer antigen that what we want them to recognize. With the Artemis technology, the T cells is equipped with enhanced cancer killing activity, and also hopefully longer T cell cancer killing activity in the tumor microenvironment. So in the interest of the time, I won't be able to go into the details of the molecular structure of the TCR that we engineered onto the T cell. But if you're interested, please check our EurekaConnectMe.com website, and I think we have our folks also post the link into the chat so that you can check out that details. So next slide. So specifically for our pediatric liver cancer program, we choose to target AFP. AFP is alpha-fetoprotein, and is a protein, is an intracellular protein that is normally produced in the baby before birth, and then it declines by the age of 1. And for many of you, you might be very familiar with this protein AFP, and it's actually an excellent kind of biomarker to monitor the disease progression. It's shown to be a kind of one of the cancer drivers in this type of cancer, and so it's ideally it's a very good target for us to target for cancer therapeutics. But the challenge here is actually, as I just mentioned, alpha-fetoprotein, or AFP, is a protein expressed inside of the cells. So how can we develop a cancer agent that can recognize this protein that is inside of the cells? So with that, actually, we develop we specifically designed a technology platform called eAlpha, which they can be specifically designed to generate highly specific antibody against this type of intracellular target. So with that, we bring this kind of technology advancement to the clinical setting, and our ARIA-2 program is actually the first proof of concept study in human utilizing this approach, and we call TCR mimic, which actually Ali just mentioned briefly. And then so if you're interested in learning more how we can target a protein that resides inside of the cell, and we have a link sent in the chat, and you can check the video, and so you can see the details. So in the interest of time, so this is my last slide. Just a brief overview of our ARIA-2 study. It is a phase 1/2 clinical trial facing pediatric patients who are between age of 1 and 21, and who are AFP positive and HLA-A2 positive, and who have relapsed refractory HB, HCNNOS, or HCC. And the primary objective of this trial is to, of course, to assess the safety and tolerability of our Artemis T cells, and also determine the recommended phase 2 dose. So this trial is currently actively enrolling patients in Dana-Farber Cancer Institute, Boston Children's Hospital, and also at UCSF, Benioff Children's Hospital. And this program was also awarded $10.6 million by California Institute for Regenerative Medicine. And also this program has received multiple special designations, including Fast Track, Rare Pediatric Disease, Orphan Drug designations. So all these awards and the designations from the government agency is actually demonstrating that their recognition of the great potential of this clinical program and the potential benefit that it can bring to this overlooked patient population. So we are very happy that this kind of our research and discovery translated into the clinical setting. And I want to say, just as a little bit of history, and this study actually was really initiated from a conversation that I had with Dr. O'Neill several years ago over an ASCO meeting, where, as many of you probably know, she is also an expert in studying AFP and its implication in the pediatric liver cancer. So she was actually presenting her poster, and then so I stopped by, and then so we had a conversation, and so we learned the challenges that this group of patients is facing, especially, of course, there's no really FDA-approved drug in the relapsed refractory setting, and also, as Ali just mentioned, many of the treatment options has lifelong side effects, serious lifelong side effects. So with that, we think it's very meaningful to bring this innovation to this population. And one last comment is we have multiple clinical programs using Artemis platform in different clinical programs. One of the most advanced program in the adult setting, targeting a different target. We have already completed the phase 1 dose escalation. And there, of course, the main kind of observation we have is the Artemis T cell therapy demonstrated to be a very safe therapy for patients so far. So hopefully that can also be translated or kind of transferred to the pediatric patient setting. So with that, I will stop here and would be very happy to take any questions you have during the discussion session.
Excellent. Thank you so much, Dr. Wang. That was incredibly informative about T-cell therapy and also learning more about the history of the ARIA-2 trial and how that came to be in those conversations with Dr. O'Neill. So with that, I'd like to now move on to the questions and answers section. And so I'm going to actually stop sharing my screen so you guys can look at our speakers while I'm going to be reading off some of these questions that we've gotten so many in the chat. You guys are asking absolute fantastic questions. And I'll let our speakers know if it's directed to a particular person or if it's to everybody, but let's go ahead and dive on in. Okay, so first question I have here is, which strategies would be best for a child with stage 4 hepatoblastoma, but they aren't eligible for transplant and it's not resectable? So I know Dr. O'Neill went over some of those treatment options there. Maybe Dr. O'Neill, briefly, would you like to kind of just, I don't know if you'd like to kind of speak high level for stage 4, not eligible for transplant, if you wanted to talk high level about those options.
I'm happy to, and thank you so much for the question. Just to give the group context, we recognize in our field that in order for a patient, first, a patient may require a liver transplant if the entire liver is taken up by tumor. Second, they only qualify for a liver transplant if they do not have disease outside the liver. So we recognize in our practice that it's very important to either try and shrink the amount of disease in the liver such that a transplant is no longer necessary, or shrink the disease outside the liver to eradicate disease there to then make the patient eligible for a transplant. And those are both challenging circumstances. And in both, we have to rely very heavily on our systemic agents or chemotherapeutic agents. Over time, I think us in the US have transitioned our approach to one that the Europeans have studied that have shown that delivering agents, cisplatin in particular, in a very dense fashion has worked better than some of the historic methods we've chosen. But we also recognize that a very skillful surgical team is prerequisite. There are opportunities to think creatively about how to clear disease in the lungs, to offer surgeries to the liver that do not require a transplant. And so what I would probably recommend, and we're always happy to help opine, is to be sure to connect with a team at a large institute that sees these diseases with frequency, because the multidisciplinary team necessary to treat complex scenarios like this is extraordinarily important.
Thank you for sharing that. That's very important. I think this next question is for both of our, is open to both of our physicians. I think it's a great question. Would an early screening protocol to test for elevated AFP to see if it's a risk factor in babies, is this something that providers might support in the future? Maybe making it one of those panels, part of those newborn screening panels, for example?
Arun, do you want to take this one?
Sure, I'd be happy to. In fact, we actually do screen with alpha-fetoprotein in conditions like Beckwith-Wiedemann syndrome, and we also screen with ultrasounds. And there's a well-developed protocol for that. Your question is an excellent one, and one that we are considering, quite actively as we try to understand what the incidence of hepatoblastoma is in certain high-risk conditions, and if it's high enough to justify the screening protocols. But it is absolutely what we do in Beckwith-Wiedemann syndrome, and an important consideration for all of these predisposition syndromes.
Excellent, thank you. Next question. So what would be the fastest process if someone was interested in enrolling in a clinical trial? Say they just found out that they relapsed, for example. And then in addition to that, how do they make the decision between different trials? How would you guys recommend that your patients go about this?
Allie?
Yeah, sure. I think the important point is that not all trials are open at all institutions. I think that's kind of number one. Number two, I think what I would recommend is having a thoughtful conversation with your child's primary oncologist. And if you aren't being treated at a center for which there is higher level information about trials available nationally, to consider a second opinion, again, at a site where a large volume of these patients are seen and cared for, because an oncologist can help prioritize what is likely to have the most data, what is likely to perhaps yield the best outcomes. And those decisions are very patient specific, dependent upon patient age, disease characteristics, genetic risk. I mean, it's not a blanket, one size fits all. So I think that prioritization is very, very specialized and individualized, and and an oncologist can help walk you through what makes the most sense for your child's context.
Thank you. Okay, a few more questions. We keep getting them in, and I'm going through them as they come in. So this is for both our physicians. Have you ever seen chemo to be curative for stage 4 hepatoblastoma? And if so, how often is chemo curative for hepatoblastoma where they weren't eligible for a liver transplant? I know you guys touched on some different statistics, but maybe we can bring some of that information back a little bit.
Kelly, do you want to start?
No.
And I can.
Oh, sure. It's a great question. I think I had emphasized this in one of my slides, but chemo alone is never the only cure. But I think if what you're asking is whether the first-line chemotherapy protocols in conjunction with surgery are curative, absolutely. And I think I had referenced the fact that we've now kind of globally started to adopt a prior European regimen, because that particular regimen, it's called SIOPEL-4. It was the point of study in the most recently concluded international trial for patients like this. It was reported to have some of the best outcomes to date, with a reasonable tolerability profile. So I think, again, every patient is different, but certainly we are curing more and more patients with metastatic disease than we ever had historically.
So another question that we got, if there is a patient with a second remission of hepatoblastoma, is it always going to be the same hepatoblastomas, or is it ever going to change? For example, so it seems like there's some questions about like the differences between if I had hepatoblastoma before, is it the exact same if it comes back? Would one of you guys please elaborate?
I can start, and then Ellie, you can add more. It's a really excellent question. So as we have sort of learned to biologically characterize these tumors, we have found a subset of tumors where there are components of both hepatoblastoma and hepatocellular carcinoma present, or tumors in which there are genetic alterations present in the tumor cells that can confer chemo resistance. So what can happen in that case is that in, for example, a composite a biphasic hepatoblastoma HCC tumor, you can treat away the hepatoblastoma component, and the hepatocellular carcinoma component, which is generally, as I mentioned, more chemo resistant, can be what recurs. Similarly, with selecting out for unfavorable genetic alterations that then kind of characterize the recurrence.
Excellent. Thank you for clarifying that. So it sounds like essentially it, although it might come from a similar start or whatnot, it could have some genetic differences essentially between, the cells that are appearing today versus those that might have been there present. So thank you for explaining that. I think we're actually at the end of the hour now, so I think I'm going to go ahead and we're going to pause the webinar, and I'd like just to take a brief moment again just to thank all of our amazing speakers, Dr. Rangaswami, Dr. O'Neill, Dr. Wang. Thank you so much for being here today, and of course everyone who's on the call. Thank you also our listeners. We're going to be sharing all of the resources that you heard today, the recording, and additional information about the topics you heard today. We're going to send that to all of the attendees in the coming week after the webinar. But with that, I just want to say thank you to you all, and I wish you all the best of luck in your journey. And please don't hesitate to reach out to us at our email address, eurekaconnectme@eurekainc.com, if you have any questions. Thank you.
Thank you. Pleasure being here.
Thank you.